Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, our monthly television program designed to keep you informed about the goings-on at your community hospital. Today I'd like to welcome a member of our medical staff, longtime surgeon here in our community, Dr. George Keckeisen. Dr. George Keckeisen, in addition to being a surgeon at the hospital, heads our surgical residency program and is also the head of our wound care program, the only one on the East End actually. And today we're going to be talking about wounds and the healing of wounds, a difficult problem for many people. So welcome, George. Thank you, Bob. Thank you for being with us. Would you tell me a little bit about yourself? I've known you for a while, as you've been around the hospital a long time, but maybe some people would like to know about your background as a surgeon.
Well, I was born and raised on Long Island, west of here. Went to college at Johns Hopkins, med school at New York Medical College. Did my surgery residency training at North Shore. 5 years of training, met my wife. We had our four children there.
Right.
And after North Shore, I did a vascular fellowship for 1 year and then went into private practice and moved out to Southampton in 1997.
So you've been here for a little while.
Yes.
Yeah, exactly. That's great. I know you're a busy surgeon too, and very esteemed member of our surgical staff. For a while, president of the medical staff as well.
Yes.
So today we're going to talk a little bit about wounds, wound healing, and let's talk first. Let's just open it up a little bit about the wound center. What exactly is the wound center at Southampton Hospital?
Right. So Wound Center is we're a dedicated group of physicians and nurses that have particular interest and hopefully expertise in healing of wounds. Wound care has become a huge topic, and it's a huge economic burden for the country. So the idea with wound centers is that you put people that are trained, have a special interest and passion about wound care, and hopefully we can address patients' wounds, get them healed faster, return them to their normal function, get them back to work, restore them to health.
And many of us often, you know, myself, I used to think, oh, a wound, you get a wound, it heals, it takes care of itself. Not always the case, and I know there's such a thing as a chronic wound. What is a chronic wound? Right.
So we all have had the experience with wounds that we cut ourselves, we heal, and the fact that the process takes place without any really involvement on or intervention on our part is kind of a miracle that we all take for granted. But then there's the patients whose wounds don't heal when they're supposed to. And we kind of arbitrarily determine a wound that's been present for more than 30 days to be a chronic wound. And by that, we would have expected the wound to have progressed to the point of healing within that 30-day period. But for some reason, and the reasons are myriad why a wound hasn't progressed to healing, is kind of our special interest and focus in the wound center.
And the goal, I guess, is to get that healing process back online, or continuing for the body to start healing itself again.
Right. So what we have to do is, if there's an impediment to healing, we have to identify what that impediment might be. Sometimes it's pretty obvious, sometimes not so obvious, and maybe very subtle. But our kind of detective role in the whole pathway to healing is to identify what are those reasons why the wound hasn't progressed to healing.
What are some of those reasons?
Well, you know, we usually like to blame the patients. Maybe they're not complying with the treatment. That actually represents a very small portion, in my experience, of why a wound hasn't healed. A lot of times the care that's rendered might not be appropriate. We kind of many times lose sight of the basics in terms of wound healing, and we go for the more exotic rather than looking for the real basic stuff. And the primary tenets of wound care involve, from the local level of the wound itself, making sure it's clean. Sounds obvious, many times neglected and not done. Cleaning a wound, protecting a wound so that the process can take place. Sometimes there's a necessity for a wound to be debrided, meaning that there may be some tissue in the wound that is not healthy or devitalized, that may need to be removed before the wound can progress to healing. And a lot of times, something basic as providing moisture to a wound may be all the things, maybe the simplest thing that needs to be done to get the wound to heal. However, in other cases, it's not so obvious, and those are the particular interest in the wound center. We know that by virtue of certain illnesses, patients' ability to heal is impaired. A classic case would be a patient who has diabetes, a patient who has a malignancy and is under some chemotherapy or other treatment. Certain medications that patients may take for other conditions may have an adverse impact on healing.
Well, I hear that often about diabetes. What is it about diabetes and wounds? How does diabetes become a factor for wound healing?
Well, a large percentage of the patients that we see in the wound center have wounds involving the lower extremities and feet. And diabetics are vulnerable because many times they have this really peculiar condition called neuropathy where their nerves and their nerve sensation is impaired. So they could be injuring tissue on the bottom of their foot and not be aware of it until it's progressed. And when it's progressed, a lot of times it's really, at that point, becomes a really medically threatening condition. They become very badly infected. Sometimes they require immediate hospitalization for aggressive treatment.
Other than diabetics, are there other people that are at risk at developing chronic wounds?
Patients who take immune suppressive medications, like many patients take steroids, prednisone, for rheumatoid arthritis or as part of a chemotherapeutic regimen or any of a number of conditions. And prednisone, or the whole group of steroids, they have a particular impact on the progression of the normal course of events in wound healing. So we kind of like to think in a simplistic way that wounds progress from several stages. The first being the injury itself. Then we identify hemostasis, where we actually think of when the blood stops clotting, we actually think of that as the first start or the beginning of the healing phase, because it releases molecules that kind of modulate the whole healing process thereafter. So you progress from the hemostasis phase of healing to the inflammatory phase of healing to the proliferative phase of healing, where the tissues are then rebuilt up, and then the body has an extensive process whereby those tissues that were injured and now become scarred are remodeled to make the scar and the healing intact. And steroids classically affect the inflammatory phase. So what we would normally expect an inflammation of a wound to take place over 3 to 5 days, on a patient who has prednisone or takes prednisone on a daily basis, that inflammatory phase may take weeks.
Wow. So the inflammation, I mean, what we associate that soreness, the redness, the inflammation is actually a natural part of the healing process, and it interferes, basically. It may make you feel better, you're not feeling the inflammation, but that's not actually a good thing, it sounds like.
Well, the inflammatory phase has to take place, so the wound doesn't progress to the next stage, and that's because there's this kind of very elaborate orchestration between the molecules that mediate the whole process of healing. So we kind of expect, and certainly as a surgeon, when I have a patient who's on prednisone, I have to take precautions or anticipate the possibility that they may not heal the way we'd like them to heal.
So somebody develops a chronic wound, how exactly is it treated? What are the ways that you would treat it?
What we first try to do is get a good history about what was done to the wound to that point. And sometimes the treatment that was rendered might have been inadequate or maybe even improper. So once we get a better handle on the wound and how it got to be the way it was, we do kind of several things in the wound center which almost sound counterintuitive. We'll actually try to take that chronic wound and make it into an acute wound. And sometimes by doing that, you can actually jumpstart the whole healing process. So in a wound that's kind of stuck in a stagnant phase, we can jumpstart it by being aggressive with debridement. Now, debridement can be done many ways.
Debridement, just for lay people, means removal of the dead flesh or the area around it?
Yes, the debridement we use either cutting the tissue or scraping the tissue or using a pulsed water lavage to clean up the dead tissue. Actually, we also use chemicals that can actually do the work of debriding better than I could do with a scalpel or a pair of surgical scissors. But the finest debriding agent, which is also the grossest, is maggots.
Really?
And maggots are...
Actual maggots.
Actual
Right,
maggots
right.
are actually farmed
Right.
and used in certain circumstances because they provide the ultimate in debridement, meaning they do a very effective job of getting rid of the unhealthy dead tissue, and they leave the healthy tissue alone.
Really?
So whatever I do as a surgeon,
Right.
there's some collateral damage from
Right.
tissue that's undesirable.
You may cut away some good tissue or something.
Exactly.
Yeah.
And so actually when we do this kind of jump starting process, we actually may create a bigger wound in the short term,
Right.
but hopefully that will stimulate the normal progression of healing to ultimately get it closed.
So it's almost like going back to trying to get the wound back to the point before it became chronic.
Exactly.
Okay.
Exactly.
Maggots are fascinating to me. We actually use some maggots here on some of the wounds? Is
Yes,
that
we
something
have,
we
and
do?
very successfully.
Right. And I'm sure these are maggots that are grown in very careful conditions, and we're not just going out and collecting maggots off of garbage.
These are the finest quality maggots
Okay.
available. But it's actually interesting that the techniques that have been around and available that haven't been utilized therapeutically, like
Right.
maggots, are actually something that somebody made the connection that, as gross as it might be,
Right.
that patient's wound was cleaner than I've ever seen it.
Right.
And I've had the same experience with, when the patient presents with a maggot-infested wound, and you say, wow, they did a pretty good job of
Right.
cleaning that wound up.
Almost like little vacuum cleaners, I
Exactly.
guess, going into the wound. What does one more question about the maggots, only because I'm fascinated about it. How long are the maggots actually left on the wound? Or does that depend, I guess? On
The
this?
maggots eat the dead tissue and then they die.
Okay.
And so they're not around for any length of time, and by that time, they've accomplished their goal.
Oh, okay. Okay. How does the doctor determine if the wound needs specialized care? Is there doctor able to tell right away if a wound needs some sort of special wound care?
Yeah, well, that's a very good question, because sometimes I'm not really certain how we get referrals to the wound center. I think in my estimation, I think a typical scenario would be a patient is under the care by his physician for a wound, and at some point, whether it be the length of time the treatment is going on, both the physician and the patient get frustrated and say, maybe there's something different we can do. Most physicians are aware of certain wounds that are more prone to problems than others, and that would kind of trigger an immediate referral to the wound center, let's say. But I think usually it's the length of duration, length of time that the patient's wound has been treated without any real good evidence that it's progressing in the way it's intended.
Are there any benchmarks? I mean, if over X amount of time that a wound, if it's really still there after a certain amount of time, it really is a problem?
My sense is that after the second course of antibiotic therapy that didn't do anything,
Right.
that's when we usually get the patients referred to the wound center.
Okay.
So that generally means that they've sought medical attention for their wound, they've been treated, and perhaps that involved a course of antibiotics, usually a week, and then they saw their doctor again and it hadn't improved, then they had another treatment, and then it hasn't really budged. And so hopefully that's the point where somebody would say, hey, what about the wound center?
All right. Any signs that a layperson could look at that say maybe, I either, number one, need to go to a doctor or to the wound center. And I guess the question is, do you need a referral to go to the wound center? Can you go directly? Can a patient self-refer, or do they need to see another doctor first?
They can self-refer. They don't require a physician to refer them. In fact, I think the most valuable referrals we get are patients that are referred by other patients. And hopefully it's because they had a good experience at the wound center and they say, yeah, I had the same kind of condition, or I had a different kind of wound, but they took good care of me at the wound center. And I think that's even a better kind of quality referral than physician to physician, let's say. But the patient certainly could call 726-3300, and they don't require a physician to be referred.
So if you've got something you're worried about, you can come on in and call that number, make an appointment, and come on in and be seen. So walk me through what a patient would expect then when they come to the wound center.
So when they come to the wound center, they're met by a very dedicated cohort of nurses and secretaries and technicians. And the first part of that interaction is an excessive intake of comprehensive medical evaluation, what their medical problems are, the medications they take. We do a thorough physical examination. The nurses will photograph and measure all the wounds. So from week to week, we have an idea about, is the wound progressing the way we'd like? Because we can look at the pictures from the month before, the week before, and so that's done on a regular basis. Once that intake is done by the nurses, then the physician would usually evaluate the patient, and with particular focus and attention to the wound. So at that point, we kind of have maybe a working idea about what's the problem with the wound and what we know what's been done to the wound, and then based on our experience and assessment, we could do one of several things. Sometimes there's a place for additional testing. For instance, since a good amount of our patients have wounds that involve the lower extremities, circulatory issues are always a concern. So we usually have, as part of the initial evaluation, vascular testing, non-invasive vascular testing that will give us an idea about whether their circulation is an impediment to healing.
Does lack of blood supply creates a problem, I guess, for wounds?
That's correct, yeah. So when we do a circulation test, we're particularly focused on the artery side of the circulation. Arteries carry the blood from the heart to all the different parts of the body. And that's the very rich oxygenated blood that is really important in terms of healing. On the other side of the circulation, the veins carry the blood back, and that is also a typical source of problems in the wound center. What we call venous stasis ulcers as a result of long-standing venous insufficiency, where the veins are not as efficient in getting the blood back to the heart as we would like. And that may be the root of their problem. So we do a lot of different things. There are patients who have had radiation in a previous treatment for whatever condition that might have that as a cause why their wound is not progressing to healing. So basically, at the initial evaluation, between the physicians and the nurses, we will arrange a plan of treatment. That may include seeking out additional consultation from other physicians. We wouldn't hesitate to get a plastic surgical evaluation as needed. We do not hesitate to order additional imaging tests, CAT scans, whatever it might be, if there's questions about the wound and that we need to have answered before we embark on a treatment. And then as far as the treatment, our expectation is to heal the wound. The obvious reason, open wounds generally hurt, and the patient has a real desire to get rid of that pain.
Real quality of life issue.
It's certainly a quality of life, and patients aren't going to school, they're not going to work, they're not allowed to return to work with an open wound, so there's certainly an incentive to get these wounds to heal. And the national benchmarks are to try to get the wound closed, and if you can't do that, get it decreased in size by at least 50% over a month's period of time. So a month of intensive aggressive treatment, hopefully we'll be able to indicate or identify that we've made the wound substantially smaller.
You mentioned other specialties. Are there, I know there's nurses and there's specialized wound care nurses. The types of doctors that are available in the wound center or available to the wound center, or other different types? You're a surgeon. Are there others that are involved up there?
Yes, so we have, we're actually very excited because we have the biggest, newest group of young physicians than we've had. We started the wound center in 2006 with 4 doctors, and now we're up to 8. And most of those new doctors are young. They're vascular surgeons, podiatrists, very involved with newer techniques. I think it's good for the wound center. It certainly infuses new blood into our program. We will not hesitate, for instance, with some of the treatments that we use, like hyperbaric oxygen. Occasionally there'll be issues with the effects of hyperbaric oxygen, and we'll need the evaluation of a pulmonary specialist to assess the patient's lungs before they embark on a course of hyperbaric therapy. Or sometimes if patients runs into difficulties as a result of what's called barotrauma, which is the effect of pressurized oxygen on the eardrums, we'll have ear, nose, and throat physicians make an evaluation and do whatever they can do so that the patient can continue the treatment.
And I've heard you talk about some of the methods of debriding the wound, including maggots. Are there other special dressings or ointments or other special medications that are unique to a wound center?
Well, we're always eager to try out new products. And the products basically are ones that are engineered to provide something in a better way, a more efficient way, a more cost-effective way, and allow the patient to remain at home rather than be hospitalized. So there are dressings, frequently we'll use dressings that are very, very absorbent. These are a class of wounds dressings that are called alginates, and they're all made from seaweed. Now,
Really?
Seaweed has an enormous absorptive capacity. So we could put an alginate bandage on, and rather than have to change that bandage 2 or 3 times a day, it may be changed but once every 5 days. So from the standpoint of the intensive nursing care that might be required, or even you'd many times have to admit the patient to the hospital for that care, we can provide that care as an outpatient. There's one of the preparations that we're using now is a medication that is it's a wound preparation that's derived from bees from New Zealand.
Really?
And the honey that they make has, and this has been known for hundreds, probably thousands of years, the benefits, the medicinal benefits of this honey. But we use that in the wound center because it has a particular role in cleaning up wounds, absorbing debris from a wound. And we've had patients whose wounds have basically healed just by using those kind of preparations.
It's amazing how many of the treatments are kind of, you hear these old remedies of, whether it's seaweed or honey or maggots even, that are really, there is some, I guess some of those old treatments have come back in some ways, so.
And I think that will continue to happen. We use, one of the things that I use very frequently when patients who have these venous stasis ulcers, now, typically venous stasis ulcers are these kind of really nasty, painful wounds that are located around the ankle. And one of the treatments that we use for a venous stasis ulcer, usually because it's usually associated with a lot of swelling in the leg, we use a preparation that's called an Unna's boot. And Dr. Unna was a dermatologist, I think, in Switzerland in the 1890s who made up this medicated paste bandage that we use frequently, more than 100 years later.
Really?
It's very effective, and I think that that's kind of the trend with the therapies that we use. There's certainly some high-tech stuff, but if you recognize the the important necessities for a wound to heal in terms of local wound care, you can provide that by things that have been used for hundreds of years.
It sounds like you're really trying to encourage the body to heal itself with using some old-fashioned techniques, actually. So,
And not only
in
that-
addition to new technologies, also, which we'll talk about in a second as well.
And not only that, I mean, a lot of, certainly with experience, I've learned that one of the most valuable things I can do is sometimes do nothing.
Right.
You know, is recognize the process that's taken place that I can't really see,
Right.
but I can see evidence of, and not do anything else.
Right.
And sometimes we can really muck things up
Right.
by trying to do too much.
Right.
I mean, to me, the fact of healing is a miracle. I mean, certainly as a surgeon, I couldn't function if wounds didn't heal. The nicest wound that I could ever make as a surgeon, really the patient's body gets the credit because they heal it.
Right, right. I've heard some doctors talk about the tincture of time. It sounds
Tincture
like
of
that's
time,
also
certainly.
important. So what about pain relief? Some of these wounds are really, really painful and hard to stop thinking about that pain. Is the wound center able to deal with that as well?
So we have in terms of what we can provide for pain control, we have the standards, standard treatments, pain medication, narcotic pain medication, become undesirable for most long-term chronic wounds for a lot of different reasons. We try to stay clear of the narcotics if possible. We'll use a lot of what are called non-steroidal anti-inflammatory agents, which also provide a level of pain control. But a lot of times with an open wound, the reason that wound is painful is because you have basically exposed nerve endings.
Okay.
And so one of the strategies that we might use in a wound early on is to provide coverage for a wound. And there's all these new bioengineered, cultured, basically skin grafts. So the typical skin graft that might be used is you use a donor, which would be you take skin from one leg and put it on a wound on the other leg. But that involves an operation, that involves hospitalization, surgery, and all that stuff. So what has been developed in laboratories are different grafts that we can cover wounds and almost provide immediate relief from pain because the wound is now covered. And these are grafts that are cultured in the laboratory. So we call an 800 number, they FedEx those grafts to us, and we arrange with the patient to have it done, and seen dramatic improvement with respect to not only the healing, but relief of their symptoms.
So it's covering up the pain. I
Yeah.
guess that's why sometimes even just a simple Band-Aid over a wound, it feels better if it's
Yeah.
covered rather than open. So hyperbaric oxygen therapy, what is it and why is it used in wound healing?
So the rationale for hyperbaric oxygen therapy has been the recognition that there are certain infections, certain conditions where wounds are particularly difficult to heal because they're associated with low oxygen tension or oxygen level at the level of the tissues. And amongst the indications or reasons we use the hyperbaric oxygen in our wound center are chronic osteomyelitis. That's an infection in the bone. So it's a deep-seated infection in the bone. And diabetic ulcers. Also deep-seated, and there's a recognized low level of oxygen at those sites. And that's one of the reasons why not only bacterial can flourish in those environments where the oxygen is low, but it makes it particularly difficult to treat. Antibiotics become less effective when the oxygen that's brought or the blood that's brought to those tissues is compromised. And the resultant decrease in the oxygen at the tissue level makes the wounds particularly difficult. So hyperbaric oxygen allows us to do two things. The air we breathe right now is 21% oxygen. Most of the air we breathe is nitrogen. So in the hyperbaric chamber, you breathe 100% oxygen. So that's 5 times what normal room air oxygen level is. And in addition to that, the air is pumped in, basically pumped in at the equivalent of 2.5 atmospheres or 3 atmospheres. So what that means is that we can get much more oxygen into the blood and therefore get that oxygen delivery to the tissues.
Okay.
And we're talking about an order of 10 to 15 times the
Wow.
amount of oxygen.
Wow.
So it's really dramatic. It turns out from a biochemical standpoint, the oxygen that is carried in our blood is carried on a molecule called hemoglobin.
Mm-hmm.
And the oxygen that we pump in the hyperbaric chamber is basically oxygen that gets dissolved in the plasma that carries the hemoglobin.
Wow.
So the effect is that by delivering an oxygen, high amounts of oxygen to those tissues, they're more responsive to healing, they fight bacteria better, the body's ability to destroy bacteria is improved, the ability of the body to increase the amount of blood vessels in those tissues is increased. So from so many different ways, it's very effective.
And I know we have 2 of those chambers here at Southampton, and those are available for people. People come in for several treatments at a time. And unfortunately, we're out of time, but you've done a wonderful job, George, in leading our wound center. I know many people have been helped by your work, and we look forward to seeing it continue to develop in all of those innovations. I may want to come up and see the maggots sometime. So, any of them have any names? No. Anyway, but thank you so much for all of your great work and your leadership and the good work you're doing for our communities here.
Thank you, Bob.
Thank you, George. And I'd like to thank all of you for listening today. I'd like to thank our friends at CTV for producing this show and airing it in Southampton, our friends at LTV for airing it in our East Hampton communities. And I'd also like to recommend that if you have any questions or you have a friend or a neighbor dealing with a wound issue, please give us a call. The Wound Center's number is 631-726-3300. They'll be very happy to help you out. I know that we accept most major insurances in the Wound Center, and also if you have a question, need help in navigating the healthcare system on the South Fork, please give us a call at 631-726-8555. Thank you, everyone, and good health.